Good afternoon and welcome to the Senior Hour, which is sponsored by Providence Holy Cross Medical Center, IMAC Med Spa, and Comfort Keepers in Home Care. I'm Barbara Cochran with my co-host,
Dr. Thomas Polucki,
on your hometown station, 98.1 FM, AM 1220 KHTS. This is a show for, about, and by seniors, giving information to enhance one's quality of life. And speaking of quality of life, our guest this morning is Marwa Kilani. She's a palliative care specialist from Providence Holy Cross. It's good to see you again. It seems like it's been years.
I know. It's been only a few months, right? Maybe?
Yeah,
before the summer.
It's like leap year. You show up every fourth month.
I know. I'm like the odd Wednesday.
The fifth Wednesday.
I'm the fifth Wednesday gal.
There you go.
Okay.
I love it.
Tell us, what is a palliative care specialist?
So palliative care is the medical specialty that focuses in on patients who have serious illness and helps to improve their quality of life. And that could be from different aspects, whether it's helping with their pain and symptoms, helping with their psychosocial standing, emotional needs. So it is a collaborative approach to medical care. And we collaborate with all of their patient specialists so that we can really enhance the treatment of their patients.
Now, are your patients more of the elderly area?
We do have a significant portion of seniors in our patient profile. And that's because, the statistics go that seniors, 9 out of 10 Medicare recipients are dealing with a serious illness.
Yes, or have been at some time.
Or have been afflicted with a serious illness, exactly.
Twice for me. So far, so good.
Yeah,
everything's under control, yes.
And so, when we're dealing with stats like that, that's a significant portion. That's a large portion of our country.
Oh, absolutely, because people are living older. They're living longer now.
Absolutely.
Because there's so many more, I think, substantive ways to enhance your quality of life. The food that we eat has changed significantly. If I ate what I used to eat as a little girl in England, I'd be dead by now, I'm sure. Because the quality of the food back then was not good, whereas it is now.
Yeah, we have really made some serious efforts to improve all the aspects of environmental components that have affected our seniors. And in particular, of course, there are all the medical advances as well. All the advances in pharmaceuticals and technology that has really brought about some pretty amazing feats in healthcare. And we're benefiting from that. Our population's living longer, they're living better, they're living healthier. And so, when you have a serious illness, you need extra care.
Yes, you do.
And you need a specialist that focuses in on the quality of life aspect.
That's right.
So, yeah, that's why I have a job. So I'm pretty happy with that. But it's a lot of fun being able to come to the community and speak on behalf of my specialty and to hopefully engage the community members to think about things such as advanced care planning and having discussions with their families and having discussions with their providers, their doctors, their healthcare team, so that they are constantly telling them what's important to them.
And I think that's so important with family members, so very important. Because I know my son and my daughter come in and stay with me on a constant basis. They take turns and stay with me because they feel that, I'm not where I was a year ago.
Yeah.
On a health-wise basis. And I think you know that because you've been improving my health.
Well, thank you. And thank you. Thank you, Dr. Kilani, for taking time out of your busy schedule to be with us here today. I'd like to address a few things that I think are, in the field of healthcare, there's so much urban myth out there.
Yes.
Surrounding your field and surrounding my field. But let's focus on your field for a second. Immediately, I think a knee-jerk reaction of most people when they hear the word palliative care, they're thinking end-of-life care.
Correct.
They're thinking that this is so bad that the only way to deal with this is just ease the transition.
Mm-hmm. Absolutely.
Right? And that is not what palliative care is. I actually thought that before I met you, and I'm sure that a lot of other people have that misconception as well. So can you clear it up a little bit? Like, what is the difference between, is it called end-of-life care? What do you call that segment of your population?
So the end-of-life care population is really under the designation of hospice.
Hospice, okay.
Hospice care.
There is a difference between hospice and palliative
That's
care.
Correct.
All right, please let us know where is the lines drawn on that? Like what qualifies for palliative care, and when is it okay? Now it's hospice.
So if you think of a patient who has been newly diagnosed with some type of serious illness, let's say Parkinson's or a type of cancer, a palliative care specialist can coincide with that person's healthcare team to help augment their quality of life. So they can actually go along with all of their treatments, even if it's curative treatments, and help enhance their quality of life, help with their symptoms, make sure that they're emotionally supported. Are there social stresses? Are they having trouble, with housing, or do they need placement? The palliative care team can help with that. There's a point, though, where it's really a line in the sand, where you are at a point where there's either no more disease-modifying treatments, such as there's no more chemo options, for instance, or the Parkinson's is so bad that they're now
there's no recovery,
suffering from pneumonias, recurrent infections. They're having much more difficulty with their movement. They're bedbound, and they need a special care team to help take care of them on a different level. And that's that end of life line in the sand. Typically, for hospice diagnoses, we say 6 months or less for a terminal illness, and it depends on the illness. Some patients outlive those 6 months. I think the statistics run, with, for instance, our former president, Jimmy Carter. There are people who are living some good months towards the end of their life with exceptional care. And their symptoms are managed and their family supported. And I think that's really where the crux of it is all at. So the palliative care team transitions to a hospice care team at that point. Same philosophy.
Is it the same people?
Not necessarily. Not necessarily. So some community hospice and palliative programs can be the same team, but typically, for instance, for the Providence team, it is a designated palliative team. It's a designated hospice team. And so those teams are doing different things. They have different focus.
Gotcha.
And it's a very deliberate process. And so the goals are established along the way, where when you're on the hospice team, comfort is the most important factor, but also the anticipatory grief that may be, experienced by the family, or the stress, the emotions that people feel around end of life, the spirituality of end of life. It's pretty tremendous. So it requires a more well-defined team. So it's a line in the sand, and it's typically the last 6 months of a person's terminal illness. Sometimes it's much shorter.
Yeah, that's what I was going to say. Typically,
could be weeks.
I have never heard that before. Like it's 6 months. It's usually like 6 days.
I know. And that's unfortunate, because sometimes people can live quite well for some weeks and even, months without things that are, aggressive care that's not really changing their course.
Right.
It's interesting because Russ went through the same thing. I went
Correct.
through the same thing with him. And he was given the opportunity of going to a nursing home, which he absolutely refused. He said, "Don't ever put me in a nursing home. If I have to stay in the hospital, I'll stay in the hospital," which is what he did. He was in Henry Mayo for 5 weeks. And he went there because of you just said it. Parkinson's. Plus, he had pneumonia and back problems. There were so many things that were going on. But we called in palliative care through Henry Mayo. And when that ceased, they brought in hospice care. But they were very open with me. They had a minister come in, and it made me feel so much better knowing that he was being taken care of and I was at the same time, but on completely different levels, which means a lot. It really does, because the pastor helped me tremendously. And the hospice care people did, and the palliative care people did. They all had different agendas that they had to follow, which you are well aware of.
Yeah.
And but it was a tremendous benefit to me, and I strongly urge, and I told my kids many times, if and when the time comes, not if, I know it will, because I'm not getting any younger. But when the time comes, I want to go through that same process.
Right.
Because I'll end up probably in Henry Mayo at some point, unless something else happens.
Right. So, Dr. Kilani, are you affiliated with Henry Mayo at all? I know you're Holy Cross.
Yeah.
But
no.
You're only at the Holy Cross facility.
I'm only at Holy Cross, correct.
I gotcha. Right.
Yeah,
so is that like a private pay hospital? Like, I mean, how does that work? Or is it affiliated with some kind of an insurance plan, or how does that work?
So Providence Holy Cross, it's a nonprofit, faith-based hospital. It's a Catholic hospital. The Holy Cross has been around for, I think, over 60 years. In that north part of the valley. It actually serves the Santa Clarita Valley quite extensively.
Yeah, they're great.
Yeah. It's a level 2 trauma center. We are a comprehensive stroke center, STEMI receiving, meaning, we take care of all the advanced heart conditions. We have a NICU, which actually is why I'm all dressed up today, is we had our NICU opening today. So we've expanded our NICU from 12 beds to 18 beds. Oh my goodness. And we had one of our NICU graduates, the mom came and spoke at the opening, and all of us were just in tears.
Aww.
And she had her baby with her the whole time. And so it really serves the community well, serves the Santa Clarita community extremely well. So Holy Cross takes all insurances, anything from Medicaid, Medi-Cal, all the way through to, motion pictures. So all the insurances are accepted. And when patients come to our doors and they have no insurance, we serve them and take care of them as if they are premier level insurance. So we don't really care about their insurance status. We provide care based on their need. And that's part of our mission, is to serve all people, especially the poor and vulnerable.
Well, that's amazing. I do know that although it's not your hospital organization's concern about insurance coverage, it's every patient's concern,
of course,
about what are my options. Like, right. I don't have the plan that's going to allow me to do this or that or the other.
Correct.
Barb, I wanted to show you something.
Goodness.
This is my 7th great-grandchild, little girl. She was in NICU up in Antelope Valley.
Oh, wow.
For 4 weeks.
Yes.
For 4 weeks. She was...
What a cutie pie.
She's only... Well, Shannon was 5 months when she gave birth.
Oh, my God. She was like a micro-preemie.
Yes, yes. And it's amazing that this baby is alive.
And I mean, and so that's some of the things, the advances, again, the technology, it's expanding. We're taking care of babies that are born at 23, 24 weeks.
Yes.
Yeah.
And now because of all of the new technology and the innovation in our NICU, there's also little cameras for our grandparents to be able to look in on, and that's so special. If you you can't get there at the bedside, you get to see them at least somehow through the app.
That's right.
So
that's what makes it all. And I've got dozens of little pictures there.
Oh my goodness. Yeah, so I had NICU babies too. My boys were in the NICU, so it's a remarkable experience.
Oh my goodness!
Part of that life journey, right?
That's right. Absolutely.
So at one extreme, and at the other with the end of life journey.
So, you mentioned a few diagnoses that would qualify for palliative. Is there any set rules of this, or it is up to the administration to decide that, hey, we need to get this special team, this person needs some special monitoring, some special services involved in order to get this person through this? Who figures that stuff out?
I think it's based on the medical team, what they think the patient needs. If they recognize that their patient, maybe, I've seen patients who are well on their way to recovery and have curative treatments. They're undergoing curative treatments. But there's something about those patients that deliberates more enhanced quality. And it could be just somebody who is undergoing significant stress while they're undergoing their treatments. Or maybe there's family dynamics, and we need to have a family conference to have discussion about, what the treatments are looking like and how to best support that patient. It could be a variety of things. It could be very advanced symptoms that are hard to control. I get a lot of symptom management requests, particularly, of course, around pain, but also around nausea, constipation, the more common things that people experience with their medical ailments. So we do a lot of real personalized medical management of those symptoms. So it's a variety of things. But no, you don't have to have a specific illness. I mean, I see trauma patients, for instance, who have traumatic, maybe they have a traumatic brain injury or have experienced pretty significant pain from the limbs that have been fractured. So it could be a whole variety of reasons why our team would be on board. But it's based on what the medical team or the surgical team wants us to get involved with.
So we need to take a little break. Okay. We'll be back in a few minutes. I'm Barbara Cochran with my co-host, Dr. Thomas Polucki, on your hometown station, 98.1 FM, AM 1220 KHTS. I'm Barbara Cochran with my co-host, Dr. Thomas Polucki, on your hometown station, 98.1 FM, AM 1220 KHTS. And we're speaking with Dr. Marwa Kilani, who's a palliative care specialist at Providence Holy Cross. And you wanted to talk about something in specifically?
Yeah. So I'm sure I'm not alone in this about the misconception, the misunderstanding, the common misconception of what palliative care actually means about that. So in our earlier segment, we talked a little bit about, some of the guidelines and who determines what palliative care really is. But I'd like to hear it from you as far as, okay, so let's just say that I was in the hospital because of a bad car wreck.
Okay.
And My team, my ER team has made sure that I'm not going to die immediately, but I'm still not able to just get kicked out of the hospital. So I'm going to spend some time in the hospital. And then my treating physicians are like, he needs a little extra help here. Mm-hmm. And they're the ones that are going to decide to call you. And then Correct. What happens from there? What does that look like? What does your team look like, and what's going to happen to someone who needs your services?
Yeah, so that's a really great scenario because that could be anybody.
Yeah.
It doesn't have to be a terminal condition.
Right.
It doesn't have to be a serious condition. It's because you're in the moment dealing with a serious circumstance. Car crashes take a huge toll on our bodies, and it could cause numerous types of injuries. And so our patients who have to be admitted after a car crash really do suffer tremendously.
Sure.
And that suffering could be on a physical level, which of course, our team is very well equipped to manage pain and symptoms. But it could be on an emotional level. It could be a spiritual level, like, wow, I escaped that car crash, but my girlfriend didn't make it. Right? So there could be components of that are significantly distressing. In fact, I had a patient once really early on when I was practicing palliative care. She was a woman who had been fully functional, absolutely healthy. She had had a terrible car crash where she rear-ended somebody on the freeway. And unfortunately, that person that she rear-ended passed away. Died on the scene.
That's got to be heavy to deal with.
Heavy. And she got away with a broken ankle, and that was it. She was so blessed to have been able to get out of that alive and relatively well. Came to our hospital, but had tremendous emotional distress about the fact that had happened to her. And we needed to be her coach, essentially, because she couldn't grasp the severity of the circumstances and how that impacted her future life, that it needed specialized care. It needed, a dedicated team to sit with her, to listen to her, to help her navigate the coming steps, to help her plan thereafter what to do. And that's what the team does. So our team is not just a physician and a nurse, but it's also dedicated chaplains, dedicated social workers. We have therapists that we work with quite closely to help make sure that we understand what the goals are for each of the patients, so that when they are doing their therapies, they know what the goal is.
Okay, so I hate to interrupt, but I need to. So when you say therapy, are you talking about psychologists, kinesiologists?
Yeah, so we're talking like physical therapy, occupational therapy, speech and language pathologists that help with swallowing. So they need to understand what those goals are. When they come to me, and I frequently get the therapists who are like, okay, so what's our goal for this patient? Because we know this patient's pretty sick. And we need to sit and say, okay, no, this is what their goal is. They want to get home. This is, not just your usual circumstance. So we have to have conversations in advance so that when they're doing their therapies with their patients, they know specifically what to look for and how to advise them and how to get them to reach their goals. So it's a dedicated process, and it's not, it's something that every physician, nurse should be able to do.
Right.
They don't have the time to do it.
Exactly.
And they don't have the expertise to do it necessarily. So our team is dedicated to it. We are there to enhance the care they're getting. And, we're certified in those specialties. So, I'm board certified in that specialty. Our nurses are certified in those specialties. We have chaplains who are certified in those specialties. So in our specialty, palliative medicine. And so this is a dedicated process because it does take a different perspective, and it's on a very holistic, whole person care model. So it's different.
Yeah, it's very different. So this is for a medical doctor. This is a postgraduate. Is it actual in, going back to med school for a specific, is it in postgraduate seminars? Is it, it's a certification, right?
It's a fellowship.
Fellowship. So a diplomate program or?
Yeah. So it's part of, it's a specialization. So just like if you had a surgeon who then wanted to specialize in vascular surgery, they would have to do a dedicated fellowship for that. It's the same thing for palliative medicine. It's a dedicated fellowship. That specialty, or this specialty, is so new. I think it may only be about 20, 25 years old. I don't think it's a very old specialty. So it's still fairly young. But it's a dedicated specialty where you dedicate, a year or 2 years of your time to palliative medicine.
Right. And when you say dedicate your time to training, is that in real time at the hospitals?
Yes.
Okay. And it's supervised by people who
faculty
have already gone through this process and have I gotcha. Okay. So.
Yeah. So even we have a fellow in our program who is undergoing what we call a community fellowship. So he's undergone a master's in palliative medicine, and he comes and dedicates a year and a half of his time to inpatient palliative care. So, and then he's able to sit for the boards, to take the palliative care boards, and then he'll be certified.
Right. And I know patients aren't going to ask that. They aren't going to ask, oh, well,
Yeah.
But
it's good to know.
You should know that this is a next level kind of situation that Providence Holy Cross is taking on. And again, thank you. Providence Holy Cross has been one of our key sponsors of this show for as long as I've been here, as long as I can remember. And again, it's just an amazing organization down there.
Well, our hospital is very dedicated to this community, and this is our community. Santa Clarita houses the majority of our caregivers. It is an extension of the community that we serve. And if we're not going to support our community, then, what's the point of all of this, right? So we look at Holy Cross at this point as a destination hospital because of all of the programs that we're serving, but it's still our community hospital. So this is, you may look to Henry Mayo as your community hospital, but Holy Cross is equally that. It's probably easier for those off of the 14 to get to Holy Cross than to Henry Mayo on certain days. So I want you to think about that for a second.
Yeah, no, I'm so impressed. We have a relationship with Henry Mayo as well.
Of course.
But Holy Cross has really stepped up. They support us. They support our show.
Yeah.
They're an amazing organization. And we hear so many great things about it. For a hot minute, I was involved in a program there that they no longer have. But I mean, it's just I think a top tier hospital.
Yeah.
In every aspect.
We've recently received a CMS 5-star rating. We are the top, listed as one of the top 50 hospitals in the country by U.S. News and World Report.
I read that. In our local newspaper, or was it the Daily News? I read it in the newspaper. I remember that. Now that you're mentioning it,
it's exceptional. It's great care, but more importantly, it's our community hospital.
Yeah,
and I am so happy that we have this hospital, being it close to home and able to serve everybody, so they don't have to drive far at all.
Right.
To go see their loved ones. So
yeah, it's just over the hill.
Yeah, it's just great. It's just great.
Okay, so I got to shift gears for a second because there is a topical situation. I don't know how many of if anybody listening right now has seen this show on Netflix.
Oh, yeah.
It's called Painkiller. It's about the OxyContin situation that was it. Thank goodness it came to light and it got exposed, and it is now mainstream information. For a very long time, it was the dirty, dark secret of the entire healthcare profession. It put a huge black mark on being a doctor, any kind of doctor, for a while there, because there were entire communities that were losing people left and right to drug overdoses that were initiated by one company that could care less. In fact, it was orchestrated. So the only reason, and I hate to bring up something so dark on this show, but it is your wheelhouse. These are the decisions that you as a palliative care specialist have to figure out and make.
Yeah, yeah. And we're very deliberate on how we manage pain because we don't want to add to that burden on our society to develop patients who are completely dependent on medications like OxyContin. So our approach is to actually take a holistic approach. First, we start off getting a very thorough evaluation of our patients' conditions. What sets off their pain? Where is specifically their pain? Is their pain affected by any particular movement? Or is it more at night? Or is it more during the day? Are you feeling anxious when you have pain? So you could see that there's a lot of things that could contribute to pain.
Sure, it's highly subjective.
Very much so. So you can't just write a prescription for OxyContin and give it to that patient because they're saying, hey, I got pain.
Right.
That doesn't work. So the way that we approach it is based on what we're healing from our evaluation. We use what we call multimodal methods to attend to their pain. And I have lots of patients who refuse to acknowledge the fact that their anxiety is actually what's causing their pain or worsening their pain.
Well, a fish doesn't think about water. When you're in an anxiety attack, you're not like, no, I'm in pain.
I'm just in pain.
Right.
And they feed off of each other too,
sure.
Correct? So our approach is let's not just give you a narcotic, but let's use other modalities. Can we do something like, for your anxiety? Are you having issues with your sleep? Are you feeling that this is more of like a spasm? We look at it from different approaches. Is this an inflammation issue? Should we use an anti-inflammatory? So we use it from different, use medications from different perspectives so that we can get to the heart of the pain, so that we're just not feeding them narcotics constantly. Right. So when it comes to I'm going to be honest, I don't even write prescriptions for OxyContin ever anymore.
Right.
Yes, I do use other modalities. I use morphine. I use fentanyl in a patch form, not anything that's street level. I use Marinol, which is our FDA grade marijuana, THC. So we use other medications to help augment their treatments so that they're not just stuck on a narcotic, which has a significant amount of side effects.
Yeah. Regardless of what is being fed to the FDA. We'll get back in just a moment. You're listening to the Senior Hour, KHTS, FM 98.1, AM 1220, HometownStation.com.
Back to the Senior Hour. I'm Barbara Cochran with my co-host, Dr. Thomas Polucki, on your hometown station, 98.1 FM, AM 1220, KHTS. And we've been speaking with Dr. Marwa Kilani, a palliative care specialist from Providence Holy Cross. And we were talking about opioids.
Oh, my goodness, yes.
Yeah, so it's a completely different game out there now. Even OxyContin has its place.
Absolutely.
Yes.
Absolutely.
Absolutely. It does exactly what it's supposed to do, but we were all lied to about how to use this. The doctors who were making the decisions for their patients were lied to.
That's correct.
And that's the issue.
Yeah.
That's the major issue. But now it's a completely different grade. A grain of fentanyl is potentially lethal. And this is out on the streets, and kids just don't know. They don't know. They could be thinking that they're taking Molly, which is a party drug, and it's really fentanyl. And all it takes is one pill.
Correct.
To end someone's life. You were saying that your facility has a thing called a nasal spray called Narcan, which can stop an OD in progress. Now, if the person isn't breathing, will it still work?
Yeah, because it's absorbed into the nasal passages, and so it could actually get them to start breathing.
And
it's a reversant.
Yeah.
That is amazing.
So,
I believe it should be in every household
every school
that has a teenager, every school, every nightclub, every bar, because you never know. I don't think any of this stuff is intentional. I don't think anybody's out there trying to do harm either to themselves or others. I don't. Yeah. I'm sure that happens on occasion, but I think there's just too many accidents that happen with this stuff.
Yeah.
It's just too easy. It's just too easy now.
It's scary. Yeah.
And you never know.
You're absolutely right.
You never know.
You're absolutely right.
So, what is the situation with that nasal spray? I need to know more about that. I'm sorry. I know this isn't why you're here, but you brought it up, so I need to know.
So our emergency room has been distributing Narcan into the community so that people have it on hand. So, for instance, I have a box at home. If, God forbid, by some chance, there is somebody who has overdosed on a narcotic within my realm, I'm going to administer that medication.
Sure. Okay. So you're a medical doctor, and that's totally appropriate. And what about?
But it could be used by anyone.
Yeah,
it's
Good Samaritan.
A Good Samaritan, of course.
You can't get in trouble for doing this. You're Good Samaritan covered by.
Absolutely.
Yeah.
Actually, I think there's a law about Good Samaritan. So if you went and tried to resuscitate somebody, for instance, if you did CPR on somebody, that person can't sue you because you were trying to be a good Samaritan. No, you can't. So I think there's laws there.
Yeah, this is LA. So
I know, who knows?
There have been a lot of articles in the newspapers about this particular situation and about the fentanyl and all that kind of stuff. And we've got a bad situation here in the Santa Cruz Valley with kids and fentanyl.
Yeah, you think, how far away do you have to be from South Central? But
no,
it doesn't work like that.
No, it doesn't.
Nope.
Absolutely doesn't.
So, yeah.
And unfortunately, for those that, become addicted, it starts off very innocent, right? It starts off with, I had knee surgery, and they gave me narcotics to take home, whether it's a Vicodin or, Norco or any of those types of medication. It starts off very innocent. And so that's why it's very intentional that we have to be mindful of the medications that we're giving out to our patients and trying to approach pain from a very deliberate, very specific manner. And so we're doing the best we can. Yeah. Especially in palliative care where, you think, okay, well, they've got serious illness. Let them take whatever they want. No, we have to be very deliberate as well.
It's even more important there.
Absolutely.
Yes.
Absolutely. Because it does affect their quality of life if we're giving them narcotics all the time. They're overly drowsy. They don't eat. They have terrible constipation. I mean, I'm talking like weeks of constipation.
Yeah, that's not good.
It's not good. It's not good. They don't take in enough fluid intake. They can go into kidney failure. There's several reasons why we want to try to minimize our narcotic use in general. But then you add the whole recreational use. That's a whole nother a whole nother beast.
Yeah.
So it's,
Yeah, and the burden is on you.
Yeah.
I mean, you have to know better than the drug rep who's coming in and telling you, well, this is this, and this is this, and this is that, because it may not be true. None of that may be true anymore.
Nope.
No, it doesn't make any difference. As long as it cures the problem, you're okay.
Yeah.
And unfortunately, that happens too often. It really does, especially with our older generation. Yeah. As you get older, I mean, seniors don't like to be in pain.
No.
They don't. You know, they figure they've gone through enough in life. They don't want pain.
But we have to be specifically mindful of our seniors because they can lose their balance.
Yes.
And, you know, that's
You
the last
can
thing
lose
we
that
need.
without even taking medication.
Right. You know, we don't want to see geriatric traumas.
Nope.
You know, we want to maintain their nutritional intake.
And their hydration.
And, you know, so there's a lot of things riding on those types of prescriptions.
And this is one of the reasons I have this walker. I don't go anywhere without that walker anymore.
Yeah.
I don't. Even in my house, I don't go anywhere.
Yeah. See, and that's smart.
Yeah, unless I have something to hold on to get where I want to go. And my son said to me this morning, he says, Mom, you're not using your walker. I said, I know, but I've got this, and this to hang on to. He said, okay. Oh, they're absolute devils with me in that walker. Use your walker.
Well, just for our listening audiences, she's got like a Cadillac of a walker, so it's a really nice one.
Well, it belongs to Jerry and Carl. Oh. They loaned it to me because Carl used to use it.
Carl used to use
Yes.
it. Well, it's fancy.
It is. Yes, it has a lift-up seat that you can put things in. And I take it with me when I go grocery shopping. I put the groceries in there,
so
too.
Once again, Dr. Kalani, thank you for your time.
Oh, my pleasure.
Thank you for Providence Holy Cross supporting the Senior Hour as one of our key sponsors. We're also sponsored by Comfort Keepers and IMAC Med Spa, but Providence Holy Cross goes above and beyond.
Yes.
Thank you.
Top tier hospital serving our community for how many years have they been?
Over 60 years.
Yep.
Yeah.
Again, thank you for your time
and
here
it's
today.
so good to see you again. It's been too long.
I know.
You've been listening to the Senior Hour, KHTS, FM 98.1, AM 1220, your hometown station.com.